Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference. My name is Nurullah Kösmene, and I am one of the residents of the Neurosurgery Department of İzmir Atatürk Training and Research Hospital. And I am proud to present this virtual meeting organized by İzmir Online Neurosurgery Platform. These online education meetings have started with Professor Hasan Kamil Sucu, the Program Manager of the Neurosurgery Department of İzmir Atatürk Training and Research Hospital, and goes on with the contributions of all the residents, also with the contributions of the neurosurgeons who graduated from the same department. I kindly ask you to keep your microphones turned off during the presentation to avoid voice and noise pollution. You can ask your questions not by turning on your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings, so please do not ask for your microphone to be turned on. And now I would like to introduce our guest. It is my privilege to present our lecturer, Professor Arjun Sahgal. Mr. Sahgal is Radiation Oncology and Surgery Professor at University of Toronto. Arjun Sahgal was born and raised in Ottawa, Ontario. Firstly, he graduated from Science at University of Ottawa, Ontario, Canada in 1997. He graduated as a medical doctor from Department of Medicine, University of Ottawa, Ontario, Canada in 2001. After graduation, he started his residency program at the Department of Radiation Oncology, University of Toronto, Canada. He successfully finished his residency program in 2006. In 2006 and 2007, Mr. Sahgal studied as clinical fellow at the Department of Radiation Oncology, University of California, San Francisco, United States, with Dr. David Larson and Mac Roach as supervisors. After that, he studied principles and practice of gamma knife radiosurgery, University of Pittsburgh, Pennsylvania, United States, in 2007. Between 2007 and 2012, Arjun Sahgal studied as assistant professor at Radiation Oncology, University of Toronto, Canada. Between 2012 and 2017, he studied as associate professor at the same department. And since 2017, Mr. Sahgal continues his studies as professor at the Department of Radiation Oncology and Surgery, University of Toronto. Professor Arjun Sahgal is member of many national and international societies. Some of them are American Radium Society, EOSPINE, Radiosurgery Society, American College of Radiology, Society of Neuro-Oncology. Professor Sahgal studied as chair at American Society of Therapeutic Radiation Oncology in 2018 and 2020. And since 2020, he is co-chair at EOSPINE Knowledge Forum Tumor Steering Committee. Since 2019, he is officer and secretary at International Stereotactic Radiosurgery Society. Professor Sahgal has over 400 peer-reviewed publications. He has over 20 editorials and over 90 book chapters. Mr. Sahgal has many national and international awards. And today, Professor Arjun Sahgal will give a conference titled Stereotactic Body Radiotherapy for Spinal Metastases. Welcome again, Professor. We are very pleased to welcome you in our online meetings. The word is yours. Thank you.
That's great. I'll just share my screen. Okay, and you can see the proper view?
Yes, we can see.
Fantastic. Well, thank you very much for that kind introduction. And it's a real great pleasure to lecture on spine SBRT for metastases. And I've met many of you over the years, in particular at the AO, and well aware of the excellent work being done in Turkey in radiosurgery. So just in terms of my disclosures, Now, spine stereotactic body radiotherapy really came around as the technology in radiation oncology evolved to allow for intensity modulated radiotherapy and image guidance. And for the first time, we could shape the dose distribution and really target areas of the spine while sparing the spinal cord to a tolerant dose. And the biggest worry at that time was the spinal cord, because the fear of radiation-induced myelopathy is one that we're always trained to avoid because it's essentially untreatable and causes paralysis. Now, the doses that we use in spine SBRT have varied over the years. And you can see there's practices of 24 gray in 1, 24 gray in 2, 5 fractions, 3 fractions. But at the end of the day, the biologic equivalent dose is much greater than what you would give with a conventional palliative treatment. And we argued in the beginning that there are going to be higher rates of local control and pain control as a result of spine radiosurgery. Now, when you look at these doses, and what I will highlight to you is the 24 gray in 2. And essentially, when I came back from San Francisco, I was doing a lot of 3 fraction, and then Sloan Kettering came out with their 1 fraction, but that caused a lot of toxicity, in particular risk of fracture. And that's when I developed 24 gray in 2 fractions as a happy medium between the fractionation schemes, and still biologically quite hot. So what were our data? And I've been treating for many years on this, and my fellow Eric Sang, who is now on staff with me, reported our initial experience. And what you see with 24 gray in 2 is that 1 year about 90% local control, at about 2 years you're getting about 80% local control, and we maintain the risk of fracture to about 10%. And what we learned over the years is that the main adverse event that we need to mitigate is fracture. So high rates of control, low rates of toxicity, and we're very happy with this regimen. And you can see here that there is real potential to induce complete response or response in these spinal metastases that you could never do with conventional radiotherapy. And this is just an example of a renal cell met that was encasing the artery of Adamkiewicz, non-surgical, and had a great outcome. Now, if you ask, why is this happening? Well, there may be unique biologic effects associated with spine radiosurgery. And what we see in these data that we helped write, and really came from Utrecht, is they had a biopsy, they did same-day vertebroplasty or percutaneous instrumentation right after the spine SBRT. So they were able to compare pre-biopsy to time of surgery post SBRT, either day 1 or the same day, and look at biologically what was happening in the tissue. So what you see here is you see a decrease in the vasculature, you see an increase in necrosis, and you see an increase in apoptosis. And it really starts to kick in by day 1, because it doesn't happen right away, these changes. But the fact that we're seeing it even after day 1 is unique in terms of biology, because you don't see this with conventional radiotherapy. But essentially what you can see is the development of necrosis and apoptosis, and that is why the biologic effect of radiosurgery may be different than conventional radiation. So we have a technique, and the question is, who should be giving this? Because it's not for any department and to be widespread without proper technology. So the way that we developed this, and there are many centers, in particular in Turkey, I know there's a big CyberKnife center, but we were dealing with LINAC-based technology. So if you're going to use a LINAC, you need to immobilize the patient properly, regardless if whatever technology you use, you need to have thin slice CT, volumetric MRI for planning, and whatever technology for delivery. Now, when you deliver with a LINAC, you need a sub-centimeter multi-leaf collimator and strict image guidance procedures, correcting for all 6 degrees of freedom. Essentially, we put the limits of our technology for this indication because it's such a high-risk treatment with the spinal cord to be spared adjacent to your target. But ultimately, we have a 95% confidence of intrafraction motion of 1.2 millimeters and 0.9 degrees, which is excellent, and it mirrors what we can achieve now in the brain. Now, how do you draw this? So it's not like brain radiosurgery where you have the target, you can see the enhancing metastases, and you treat it. Here, you can't really see the tumor on an MRI or CT. It's much more permeative and infiltrative. So we draw a clinical target volume. So you're treating the anatomy at risk. So if you have, say, for example, in the middle pane, the vertebral body involved, the ipsilateral posterior element, we take the entire vertebral body and ipsilateral posterior element into the treatment volume, and then we treat. And these contouring guidelines have been published and represent a standard of care. Now, there is some data validating this practice as we learn over the years that if you treat only what you think you see on the MRI, your rate of failure is increased. And these are some good data from Johns Hopkins, where people either had a deviation from the international guidelines or not. And what you can see is local control is better when you do not have a deviation as opposed to when you have a deviation. And the failure rates really were in the no deviation, you start to see those adjacent compartment failures, okay? And that becomes to be more significant, when you have a deviation than when you don't have a deviation. And that's what gave the statistical significance. So here, in this case, where you should have treated the contralateral pedicle and posterior elements, you failed there, and hence that's bad practice. You should have adhered to the guidelines and covered that anatomy. Now, what about the spinal cord? Well, here it's a challenge. You can either draw it and spare it in 3 different ways. You can draw the cord itself, you can draw the cord and then put a safety margin, which is what we do of 1.5 millimeters. And in the old days where we couldn't really fuse the MR images and see the cord, we were drawing the fecal sac, and that was the basis of a lot of the early work we did on spinal cord tolerance, because you couldn't accurately delineate the spinal cord. But my practice now is 1.5 millimeter PRV. Now, regardless if you want to use a myelogram or MR simulation, if you use proper MR simulation, you don't need a myelogram. It's very rare that you do. And in some situations, like you see below, where you have X-band artifact, you're in the cervical thoracic junction, so you've got the curvature, your planes of image acquisition are bleeding into each other. It doesn't matter what you have, you just can't do it. And in some cases, you can't do it, but these are few and far between. But a good MRI, you should be able to delineate it, and you don't need a myelogram. Now, what about below where the cord starts to form the cauda equina? Well, here we contour the sac because the nerve roots are dancing in the CSF. You can't accurately delineate individual nerve rootlets. So we draw the sac, we spare the fat and the peripheral nerve roots as they go out, and we spare this without any safety margin. And at the end of the day, it's better to be conservative. These are metastases patients, and not cause the complication of cauda equina necrosis. So we follow it down and we create what we call an avoidance structure where the nerve rootlets live. Now, what are our dose limits? Well, we've done this for years, and some of the early work I did back in 2013 really established safe dose limits, and they were thought to be somewhat conservative. Then with the high-tech group, we modeled the data with some further analyses, and we came up with what I call the higher end of the range of dose limits to the spinal cord PRV in 1 to 5 fractions. Now, I had gone to a middle ground many years ago, and we've been treating with this for years, not seeing any complication. And I recently have migrated to this higher dose limits when you have epidural disease, because there it's worth it to take the risk. What about the retreat? Well, here we don't have a lot of data since my original publication in, I don't even remember, I think it was 2016. But at the end of the day, these are conservative dose limits for reirradiation. And I upped these numbers by 20%, and we've been doing well. And we published our data, but these are few and far between, but we have been escalating the reirradiation dose. But are we justified to do this? And that's the question that you have to pose. And what is the randomized evidence to prove that SBRT is similar to conventional radiation? Because the radiation oncologists were the ones that were hindering the development of spine SBRT because they like giving conventional palliative radiation, and they didn't feel that it was warranted to treat the patient with metastases with more aggressive therapy. It's just like the old days in the brain. They want to give whole brain. We're pushing radiosurgery, and now whole brain radiation is really no more. It's only for very specific indications. Radiosurgery has taken over, and so it will in the spine. So what are the data? Well, we first have the phase 2 randomized study from the Germans looking at 24:1 versus 30:10 conventional. This was a sample size of convenience, so it's not powered. Now, what they did show was that complete response rates were better after 3 months, trend in terms of significance, but after 6 months, they found significance. But again, this is not powered, but it's good data showing the signal that you can really improve the complete response rate for pain. But they found that the risk of fracture was 28% versus 5%. But don't forget, they're giving high doses of 24 grain 1 fraction, which we know is associated with higher rates of compression fracture. And so then you come to SC24. So this is my randomized trial that we designed. And in fact, the German study came out during this time and informed our sample size. So we're very happy with that result. And we had designed this with 24 grain 2 versus 20 grain 5 of conventional radiation, 1-to-1 randomization. The primary endpoint was the complete response rate for pain at 3 months, and we had various secondary endpoints. Now, what's important here is you had to identify the target vertebral segment that had pain, so that's in red. If you treat that with SBRT, you treat that level. If it's conventional, typically 1 above and below with conventional radiotherapy fields. Now, as you all know, you have multiple levels involved at times, but if you could identify the most painful segment, we allowed for up to 3 contiguous vertebrae to be treated in the volume. So here you treat all 3 levels with SBRT, you track the one in red. If it's conventional radiation, typically 1 above and below. You could treat other levels as needed, which whatever way you want, but we had to track the red target. And that's important because that's how we determine the pain response. So in terms of trial profile, we randomized 229 patients, 115 to conventional, 114 to SBRT. We had dropouts associated with death or for other reasons, but not a major amount. And we had an intent to treat analysis. So if you look at the majority of patients, they were breast, prostate, or lung, no surprise. Radio-resistant were the minority as opposed to radiosensitive, because again, that's the majority of patients that come in. But the majority, about 2/3 of the patients had either bulky disease or epidural disease, and that's what we call mass. And our median SIN score was either stable or unstable. Pain score was 5. So this is very representative of patients who we would see for radiation, not those ones that need urgent surgery or stabilization surgery up front. So what did we achieve? Well, at 3 months, we found that the complete response rate was significantly greater, 21% absolute improvement, and that was significant. At 6 months, it held true, and you're getting a significant increase in complete response. And why this is important is because there's no variation here. The pain is 0. And we adjust for pain medications in the International Complete Consensus Response Criteria. So it's not something where, oh, I feel it's like a 3 today or a 4 today, or if they're saying I have no pain. And that's why this endpoint is important for standardized clinical trials. Now, toxicity-wise, we didn't see a lot of toxicities, very low rates of grade 2 to 4 toxicities. We had 1 grade 4 vertebral compression fracture rate in the conventional arm, but overall, no significant differences. In terms of any compression fractures, 17% in the conventional arm, 11% in the SBRT arm. And this is with the caveat of up to 6 months of follow-up. So no significant difference. We do see fractures, no radiation myelopathy, and we applied the 17 grade dose limit to the cord PRV, which is based on my early work. So everything is evidence-based. We had central imaging review, we had central planned QA review with very few major deviations. So we conclude that spine SBRT is superior to conventional radiotherapy, 21% absolute increase in complete response rate at 3 months, and it was durable at 6 months. It's the first phase 3 study to show that dose escalation to spine mets, or bone mets for that regard, improves your pain response rates. So therefore, 24 grain 2 is safe and non-destabilizing and represents a global standard of care. Now, what about RTOG 0631? Because this was presented in abstract form even before I reported my results, and it's still not published. So we don't know what's going on. We see that it's a negative study, so there's no benefit in terms of pain response or complete response rate. And we have to wonder what's happening. So only once we see the trial and understand it can we make any assumptions. Otherwise, at this point, we don't know what these data mean. Now, people ask me on my study, what happened after 6 months? Because we only followed them for up to 6 months. So I'm going to show you some data that we recently published. So we looked at just the Sunnybrook Toronto cohort because we randomized 2/3 of the patients, or about 60% of the patients. So we had 137 patients from my organization. And we followed them even after the trial with MRIs so that we got long-term data. So we had 137 patients of the study, 66 were on the SBRT arm, 71 were on the conventional arm. Now, what's important here is that we analyzed every spine segment that we treated, not just the target. So that increased the numbers, okay? And so we had 119 spine segments on this SBRT arm and 169, because remember, you could have up to 3 consecutive segments. So now we're improving the detectability or the sample size in terms of what we're reporting. And what we observe here, I'll show you first local failure, better with SBRT versus conventional in the long term. When we look at the failure rates, whether or not they had bulky disease, so mass. So what we see is that if you have bulky disease, your failure rates are highest with conventional radiation. If you have bulky disease, then you do have increased failure rates with SBRT, and both in comparison to when there's no bulky disease. So this mass is a negative predictor for both conventional and stereotactic, but the rates of stereotactic radiation are better than with conventional radiation in terms of local failure. Now, if you look at reirradiation, lower rates of reirradiation with SBRT versus conventional because they're not failing as much. And this is just our fracture-free survival also showing that the rates of fracture were not different in the long term. Now, I will say when you did get a fracture, the severity of the fracture were greater in the SBRT arm. So we had more fractures requiring surgical salvage in SBRT versus conventional, and that's one of the differences between the two. So you're gaining with respect to local control, you're still fracturing at the same rate, but when you fracture, you're more likely to have an interventional procedure. And this is just a table summarizing those results at 6 months, 1 year, and 2 years. So good long-term data to help inform patients. But what about the histology? Because we have a lot of different histologies, and what's the impact of histology on outcomes? And there was a lot of discussion that, oh, there's no more such thing as radio-resistant anymore, but that's not true. We know the failure rates are higher with colon cancer in particular, and some radio-resistant histologies, for example, renal cell, melanoma, thyroid, and sarcoma. So we looked at it to the form of separation surgery, really starting from Sloan Kettering, where they realized the goal is to decompress, resect the PLL, give you a nice space around the cord and free up the thecal sac, and then go ahead. But this was still major invasive surgery. And with minimally invasive surgeries like tubular decompression, percutaneous screws, you don't necessarily have to do this to achieve separation surgery. And you should be evolving towards less and less invasive techniques as these patients have metastatic disease. Now, there's some good data from Japan that actually combines separation surgery with 24 grade 2 post-op SBRT, showing very good rates in terms of local control, so low rates of local failure over time. And again, very good functional outcomes for patients as well, in the sense of regaining ability to walk with the combined approach. So overall, I think everything is pointing towards this being more and more of a safe standard of care. So in someone like this, with some low-grade epidural disease and previous radiation, maybe it's a Bilski 1C or 2, we do tubular decompression, free it up, give me a nice space. Now I'm a Bilski 1A or a 0, treat with SBRT, and follow the patient over time. And this is really where we're heading on those more complex epidural cases. It's not for everybody, but when I know I need to spare the spinal cord because of previous radiation, I really want to try and downgrade the epidural disease. Now, there are ISRS guidelines for postoperative treatment. There's not a lot of data. These guidelines are there to promote safe practice, and it is a very detailed overview for you to reference. So what about some of the late toxicities? As I've shown you a lot of the early work, and we have it from the randomized trial. We have a lot of data retrospectively of fracture, but how do they do in the long term? Because this is what we have to worry about, because these patients are now starting to live. And the one that we knew was that fracture is our problem. So this is an example of a patient who had 24 grade 2 fractions. Lo and behold, fractured down, had a baseline fracture, was high risk. It was melanoma, and fractured 5 days later, but there were no tumor cells, but there was a lot of inflammation and hemorrhage. So it's a powerful technique, but we have to be careful with the bone. So we looked at predictors with the MD Anderson and Cleveland Clinic, and what we found when in a cohort was that if you have a baseline fracture, your risk is much greater of further fracturing. If you have malalignment, lytic disease, and if you hit it with a high dose per fraction. So if you go high dose single fraction, you're going to have a much higher rate of fracture, about 40%. Now, if you go 20 to 23 per treatment, so 20, 23 in one fraction, you're about 20%. And then when you're under 19 gray per fraction, about 10%. And that's what I do, 12 gray times 2. When I escalated to 14 gray times 2, I didn't see any change in incidence either, because you're keeping that dose per fraction low. Now, the severity may be higher, but the incidence is the same. So this is why we promote a bit more fractionation into the schedule versus high dose single fraction. Now, we found these fractures happening within the first year. So these are relatively acute fractures, but Sloan Kettering with their 24 gray 1 were finding late fractures. And that's because there are two different pathophysiologies. There's the acute destabilizing event that happens early on, and maybe those patients would have been better off with a percutaneous instrumentation procedure or cement. And then there's the long-term patient whereby the bone is crumbling with the late effects of the radiation and fracturing over time. And you see in this case, there's radiation fibrosis and necrosis 24 months later. This was not tumor progression. This was smoldering necrosis, weakening the bone. Now, the good thing is that the majority of patients can be salvaged with cement. So it's low risk procedure, cement, and we're arguing more and more about trying to do this preemptively in high risk patients. And so those patients with baseline fracture, lytic disease, malalignment, intermediate sins, or frankly unstable sins and mechanical pain, or if you're really going to blast it, then maybe you should do a preventative cement augmentation procedure. And these are just some recommendations from the AO Spine Tumor Knowledge Forum. Now, there is some data, and this is interesting data from Bob Timmerman in Texas. So they looked at patients who had baseline pain, who did not have a fracture, and that's important. And they cement augmented them, and then they treated with SBRT, and they had a variety of locations and indications. So what they found was their 3-month pain response was actually really good, 95%, and good control, but 29 patients. The median sins was 6, but 10 of them were 7 or greater. So 10 of the 29 were intermediate sins. So these are good data, and they're showing you that more and more this combined modality therapy is going to help the patients probably better in terms of stability, but also pain response. But I tend to do it after the SBRT, not pre. And the reason is that you can dislodge tumor cells, and we know this. This is some examples of subligamentous spread and epidural venous plexus spread as a result of the cement augmentation. And there are data that show if you measure the CTCs after a cement augmentation procedure, you will detect tumor in the bloodstream. So no surprise, you're in there, you're spraying cement, and you're spraying all the tumor cells as well. So at least if you treat first, then they're cells that have been radiated and theoretically on their way to die. But these are just some important things to think about. But some patients have a lot of mechanical pain, they can't get through the procedure, cement them first, and then treat them. So what about skin toxicity? And this is one that we don't talk about a lot because we don't see it, and it's a long-term effect, but there are patients where we do see long-term late skin toxicities. And this is an example of a sarcoma met that I treated with 30 gray and 3 fractions. This was very early on. And there was some French data showing good results. Again, in today's age, I treated with 28 and 2, but seeing some long-term telangiectasias, woody fibrosis of the back, and skin changes, but not necessarily too bothersome to the patient. Sometimes there can be some chronic discomfort. We have seen some weird things though, and this is a patient treated with 28 gray and 2 fractions and done great. No hormones, no chemotherapy, nothing. And 2 years later, just spontaneously, we saw skin necrosis. And we just don't know why. It tends to happen when we treat these posterior element disease, likely because we're really concentrating the dose there. But this is very bizarre. But these weird things can happen, but they're rare. And another rare side effect that we really don't talk about is myositis. So in these patients where you're treating a lot of that paraspinal muscle or into the psoas muscle, we can see this inflammatory response, and it can cause pain and discomfort. Now, it tends to be higher with the high dose single fraction radiation than if you fractionate. Again, more of an argument for fractionation. And you can see here all this muscle change that happened as a result of the radiation, but the contralateral muscle that's spared from the high doses looks relatively intact. But even these little areas where we're allowing dose to go in to achieve the goals of treatment, you can see that inflammatory change. And essentially over time, you start to see atrophy of the muscle. But this is inflammatory reaction within the muscle. But it all brings us to the issue of radiographic response. And this is the issue that we face with right now. So how do we characterize response radiologically? Because we're following these patients with MRI. We don't really know what those signal changes are over time. And those criteria like RECIST really don't apply to the bone. So a lot of work that we did in the spinal group many years ago, we're trying to standardize the imaging response, saying that it is an MRI follow-up that you do. You need to interpret this with the neuroradiologists and the radiation oncologists. And local control is hard to know, and it may be an absence of frank tumor progression, especially over serial scans. Local progression could be a gross, unequivocal increase, new progressive disease within the epidural space. Let's say you're neurologically deteriorating, and you had epidural disease, and it's likely the epidural disease causing it, then you have to code it as such. And this is what we used for the randomized SC24 study. So we used at least a criteria. Now, one of the issues that we'll talk about is pseudoprogression, because that can occur. And this is all with the caveat of very strict treatment planning in terms of the image acquisition. And we also make recommendations of pain response, and that patients should be followed every 2 to 3 months for the first year, especially because that's when the fractures are happening, and then usually every 3 to 6 months after. So this phenomenon of pseudoprogression is there. So this is some imaging-based data where you can see we treated this patient at a sclerotic prostate cancer metastases. You saw some darkening in the bone, and then it starts to regress or stabilize. And that's pseudoprogression, just like we know what happens in the brain. And this is work done by one of our neuroradiologists, Dr. Marilani, who's really spent a lot of time and work trying to standardize this. And we're almost at the point of having some linear dimension criteria. So it's very exciting, and it's coming. We have some volume-based, but the problem is that you just can't draw these things on routine scans and get a volume. You still need a linear dimension to make it easy to do in the clinic. And this is an example is failing it in multiple vertebrae. So this is an example of true progression. So what's important here is follow the patient. Don't be so quick to judge progression on one MRI. If the patient can have a second, then qualify it, because we do see pseudoprogression in about 37% of patients within the first year. And there are late pseudoprogressors that happen as well. And it may be more in lytic, bulky type tumors like renal cell, as opposed to sclerotic lesions like prostate cancer. Now, what do you do when you know that there's failure? And that's the question, because you know you're going to get failures, but what do you do at that point? Have you exhausted therapy? They've had radiation maybe once, you did SBRT, and is that it? Well, we've been salvaging them with a third course of stereotactic body radiotherapy or a second SBRT if they've only had one. So this still is the most dominant series in the literature. 56 spinal segments, reirradiated. So this is salvage SBRT for SBRT failures, but you can see here that these are well selected. So low-grade epidural disease, and we treat mainly with 4 fractions because the principle is to increase the number of fractions to increase the safety because they had already seen mainly 2 fractions already. So we saw good local control at 1 year, 80%, but we also see the majority of these patients are dying. So these are at the end of life. So 50% of these patients are alive at 1 year, and you have to consider the toxicity results as a result. So what we did was we gave very detailed data in terms of the cord PRV and thecal sac doses from the initial, and 24 had conventional radiation, had stereotactic radiation with 2 fractions, and then a third course, okay? And we give you the cumulative total biologic equivalent doses for you to kind of understand what your practice is. But essentially, I go to my retreat limits and I go with the most conservative, and that's how I treat. Now, if there's patients with 1 SBRT course and a second, so no previous conventional, again, we've given you the numbers to understand what is cumulatively safe. And again, I have not caused radiation myelopathy or Codd-Aquino syndrome, but we have caused neuropathy. And that's one of the more nuanced side effects in terms of neural toxicity that is going to become more and more of an issue as we do this treatment more. And it stems from the fact that the peripheral nerves, we really don't spare them. And the myelination is different, the tolerance is different, and there are a lot of different issues. And so this is just a schema from Josh Yamada, Sloan Kettering, that shows that brachial plexus nerve root and the lumbar sacral nerve roots. But there is a fundamental difference. The brachial plexus nerve roots are traversing horizontally through the tissue, as opposed to lumbar sacral nerve roots coming down, and you end up treating a lot more of the lumbar sacral nerve roots that drape down anteriorly through your vertebral body, which are larger. So you end up treating a larger volume as well. And there may be a volume effect in the peripheral nerve roots that isn't there in the central spinal cord or Codd-Aquino nerve rootlets. And that's what I think. So we looked at our data. So we looked at our mature outcomes. So we want to see, well, how are those patients doing that live 3 years or more? And we looked at our data of 600 patients. So what we found was that the patients living less than 3 months were actually few and far between, only 52. But we actually only had 79 patients living in the long term as well. Now, these are some older data that need updating. But what the data show is that we still see vertebral compression fractures over time. And again, respecting our rate of about 10%. But we start seeing those plexopathies increase. And the plexopathies tend to occur in patients who were previously radiated. We only had, I think, 1 patient with 1 course of SBRT. And the problem with the plexopathies, and again, they're mainly in lumbar sacral plexus, is that there's no really good treatment. And it's a pain, it's a discomfort. It can cause foot drop, it cause weakness. And this becomes a very it's a distressing side effect for our patients. And again, there's no good treatment. So we have to be mindful. It's still a 3% risk at 3 years and a 5% risk at 5 years, mainly in patients who were previously radiated. And most recently, there's actually another series from Japan that came out looking at their reirradiation SBRT experience. Again, it's a smaller series, okay? There were 19 lesions in 17 patients, but they retreated with SBRT. So really kind of mirroring my earlier work. And what they show is good rates of local control, but they're showing the plexopathy. And in their 4 cases of plexopathy, again, heavily previously reirradiated. And they're seeing this toxicity, but good rates of local control. And again, the overall schema are quite similar to what I published before. So at the end of the day, it's a toxicity that we want to be mindful of. It's something that we have to understand better. And the way that we've been managing it right now is contour the nerve roots and no more than 105%. So no hotspot in the nerve roots. We definitely are more mindful in the lumbar sacral plexus. And something that we were evolved to is to treat more four fractions in those where the brachial plexus or the lumbar sacrum is at risk, to try and mitigate it. And we have some four fraction data that we're submitting of 30 gray and 4 that should standardize that approach. And I really do like it. I think it's important. It may mitigate some of the fracture risk. It may mitigate the lumbar sacral plexopathy risk. And that's the main impetus driving our four fractions. But at the end of the day, it's a work that we have to understand more about this toxicity, because it will become more and more of an issue. So I would say in conclusion, spine SBRT is an established field with great promise. Clinical practice is evidence-based. SE24 is a positive trial, so there's level 1 randomized data supporting spine SBRT. 24 gray and 2 is the preferred Canadian fractionation scheme. Fractures we still have to learn about, but we're getting there and we're understanding more about ways to mitigate the risk. Standardization of SBRT trials is very important for imaging response and pain response, and we have the spinal criteria to guide clinical trials. We're understanding more and more about MR signal changes. Salvage SBRT is an evolving field. And similar to brain radiosurgery, there'll be much more and more spine SBRT, and it is something that's blossoming in our field. And for those of you who are interested, we recently published a second edition to our image-guided hypofractionated stereotactic radiosurgery book. And with that, I would say thank you very much. I'll stop sharing and time for questions.
Thank you, sir. It was a great lecture. I have a question firstly. After stereotactic body radiation therapy, how do you follow patients? For example, how often MRI scans?
So we are very strict here. We do an MR full spine every 3 months for the first year. At the second year, it's usually 3 to 4 months, and thereafter somewhere between 3 to 6 months. But if it's something like prostate cancer where we can monitor the PSA, sclerotic, low risk, I think every 6 months after the first year is okay. But your main fractures are happening within the first year, so you need to follow them carefully. But then after, you can space it out. But it's not something where we don't follow. We always follow them because you can see high-risk catastrophic fractures in the long term.
Okay, thank you, sir. In the chat part, Dr. Said Shirin asks PET-CT role in follow-up.
So we would love to do more PET-CT follow-ups because you're getting some type of biologic imaging. We can't get in Canada, it's too hard. But I think the PET-CT can complement the MRI because we don't really know if they've responded in terms of the tumor on MRI. So together, I think it's a great way to follow, or at least space it out. Maybe a PET-CT every 6 months while you're doing MRIs would be a very nice, happy median because, you know, you're getting more information, and we love it.
Okay, thank you, sir. I don't see any other questions or comments. Yes, one more we have. Professor Kamil Sucu asks if there is vertebroplasty, kyphoplasty incision, should we perform the procedure before or after stereotactic body radiosurgery?
So again, so what I believe in, I think you should do it after. I think you should treat the cancer, and if you're going to disseminate the cells, which we know you will, then they're treated. So my preference is do the SBRT first, and even the same day or the next day, and that's what the Utrecht data show, you can do the cement, and it's totally fine. But if the patient can't lie down because the mechanical pain is so great and you can't get them through planning, then cement them first and then treat them.
Okay, sir, thank you. Okay, there is no other questions or comments. Professor Hasan Kamil Sucu.
There's a Said Shirin, Professor Said Shirin among us. He is a professor dealing with extensively cyberknife and other procedures. If it is suitable, I want to hear his opinion. Professor Sayed Shirin, can you make a comment?
Of course, it was a great talk by Arjun. I got chance many times at the same ISRS or other SBRT meetings in US or in Europe. And we do a lot of spinal mets with CyberKnife. And I would like to have him to underlie about the platform to do the proper spinal radiosurgery for mets. What kind of platforms or what should be the accuracy of platform to do spinal SBRT for spinal mets? One of the requests is this, and the second is actually, does he still have the suggestion to do pre-operative radiosurgery and then doing radiosurgery? Surgery after radiosurgery. The second question is this. I mean, namely pre-operative radiosurgery and then doing decompression and other instrumentation.
Sure. Wonderful questions, and I do remember you, and nice to see you again. So I think the platform, it doesn't matter. Like if you have a CyberKnife, great, because it was actually meant for spine SBRT. That's why John Adler made it, you know, in particular for the brain and the spine. The treatment times are long, so the LINAC technology has really evolved so that you can deliver the treatment in 5 minutes even per fraction. So I think there are differences, but you need a lot more different equipment with the LINAC. So certainly we know this CyberKnife is safe. It's got a long history. It's a beautiful machine, especially now with the iris collimator and your multi-leaf collimators and everything, that you can really do a lot more than in the old days. And I trained on the old model, you know, at UCSF. There were treatment times were much longer. We had to change the cones. So there were some disadvantages at that point, but the technology has really evolved. So I think it's fine whatever technology you use, as long as you follow the proper imaging requirements. The second point about pre-op is very interesting. The only thing is that for me, and why I'm not too keen on it, is it's not like the brain, whereby you know that you can go in there and do a gross total resection. The intent of preoperative is to avoid leptomeningeal dissemination. Here we don't have that issue in the spine. And so, you know, you can do it, and then if you didn't achieve an adequate decompression for whatever reason, then you're left with it. And then what do you do? So it's the bone, it's not in the brain. We don't have that same issue of dissemination. What I would say is do the surgery first and then do post-op, because you've decompressed, you're going to get a better dose distribution, more dose to the residual, and less dose to the spinal cord or cauda equina. So I'm still not completely convinced about pre-op spine SBRT, but I certainly love it in the brain.
But Arjun, you know that instrumentations may cause a lot of artifacts about delineating the spinal cord, the screws and the rods. You know, I have hard time. I mean, to do those things, and sometimes I really think about doing a CT myelogram.
Yeah.
To better delineate the spinal cord.
I agree.
Yeah.
So I agree. So my own experience is this. But one is that don't instrument at the level. I think that's the most important thing, and above and below. But with thin slice, good MRs, so that's T1, T2, especially a proper weighted T2 image, I've never had to do a myelogram, and we can always see it. So I'm not too worried there. Now, sometimes you do, and that's the price. But if they've got high-grade epidural disease and you have to spare the spinal cord, because you always have to spare the spinal cord to that tolerance dose. then you're still going to get more dose to the epidural disease. So I just think that I'm not too convinced. With carbon fiber screws now and everything, you know, you're going to have like no artifacts. So that's a positive. So I think it kind of depends on your technique and your imaging. And in some situations, if that technology isn't there, then you may want to do it. It's just, I'm not too sure, you know, yet.
Okay. Thank you.
You're welcome.
Okay.
Thank you, Professor.
Nurullah, I
Professor
think
Kamil Sucu.
we have no another question or comment. I want to thank again Professor Arjun. It was a fantastic lecture indeed. And I want to thank everyone who joined us today. Thank you so much.
Thank you so much for inviting me.
Thank you.